This one's fine. There it is.
Yep, there we got it.
Hello.
Check 1, 2, 13, 9, or 14. Okay. So we good to go now? Okay. All right, we got the microphone on. Madison Smith's here, so we can get started. My name's Nate. I'm one of the nurses with MedFlight. I used this lecture last year as well, so if you're here, there's lots of the same stuff. So we're going to talk about behavioral patients because there's no part of healthcare that's immune to taking care of the behavioral patients, and it's an ever-growing area of need. Some disclosures like Scott had, and then we'll talk about kind of towards the end of this. We'll be able to define and constitute what a behavioral emergency actually is. By the end of the presentation, we'll talk about 2 symptoms of excited delirium. That is one of the most critical behavioral emergencies that you'll face. We'll talk about common treatments for each behavioral emergency, and then we will also talk about 2 questions that you definitely need to ask anybody that's claiming to be suicidal. So behavioral emergencies, what is it? It can happen to anybody, and to anyone and anywhere, even those that are medicated. We may be called because someone can regain a grasp on reality. The thing to remember with behavioral patients is they can be a danger to other people. They can be a danger to themselves and their surrounding. But what they're living typically is very real to themselves. And then when they're also psychiatrically impaired, they don't make good choices. They can't. Some of them can't provide their own food, clothing, shelter, and just basic human needs. Statistically, it's pretty prevalent and it's still on the rise. Very common. 1 out of 5 people will experience a mental health crisis in their lifetime. The thing to remember is about 1/4 of the adults with a serious mental illness don't seek treatment. I think this lends a lot to what we see when we talk about suicide. The other thing is people with mental illness. It's a chronic condition, just like most people with any chronic medical condition. So they're gonna within 30 days they make a bounce back to the emergency room. About 15% of them will return. So a pretty high incidence. A lot of them are going to be transported by EMS or have some kind of first responder, law enforcement involvement in that situation. 68% of the adults with a mental illness have a medical illness to come with those. I mean, those can be anywhere from that 18 years of age, that new adult, if you will, that we see a lot of geriatric people that are carrying some kind of mental illness as well. And then the other thing to remember is 29% adults with a medical illness have a mental illness. So if they've got something medically going on, almost 30% of them will have something mentally as well. So there's different types of disorders. There's disorders of thought. It makes them not have the ability to think correctly. You're going to see those in schizophrenia, mania, and delirium with that. Have disorders that affect their mood. So this time of year, especially, you get a lot of depressed people because the clouds roll in. It gets kind of dark and gray skies. The seasonal depressive disorder and depression. What's interesting is I read a study one time when you start looking at the Pacific Northwest and then trailing on up into like the Juneau, Alaska area, their incidence of seasonal depressive disorder and depression in general, because those areas are cloudy and not a lot of sunshine, is just astronomical and off the charts. The other type of disorder is going to be anxiety. They create an unwarranted sense of urgency. And probably the one we see kind of the most, especially in the first responder type community, is the post-traumatic stress disorder, because we do deal with that quite a bit. So in looking at schizophrenia, it's probably the most well-known mental illness. Um, with schizophrenia, what is real and what is not real are the same in these patients. These people, when they're having a psychotic break and they're schizophrenic, the thing to remember is those hallucinations and the false reality and delusions and things of that nature that they're experiencing is very, very, very much real to them. Probably the one of the most interesting patients I've ever taken care of is someone that's truly seeing visual hallucinations, that realizes what they're seeing isn't correct, but it is also very real to them and they can talk their way through it. A lot of patients, unfortunately, can't talk their way through it. And so um, it causes a lot of problems for them. They decline in their mental function. A lot of them will withdraw because in their reality, they're very scared, and don't know how to cope with that. They'll ultimately have problems at work, with relationships, because they truly have a problem realizing what is real and what is not real, and then they have problems with themselves as well. You will typically see a lot of those folks, because of the mental burden that they have. They'll start to get where they're not sleeping well, and then you'll see incidents of suicide, and so they just have a problem coping and dealing with themselves as well. If you look at depressive disorders, major depressive disorder um, is something that is, unfortunately, is very much a real thing in life. Typically, it comes with a profound feeling of sadness, and bad things definitely do happen to people. And it's a normal part of life that not everything is full of sunshine, puppies, roses, and all the things, positive things that we want. When it becomes prolonged, though, and they can't pull themselves out, that's when it slips into the major depressive disorder. There's a book called the DSM-5 that the patients, um, that we use to diagnose psychiatric conditions, and these patients with major depressive disorders are going to have the symptoms nearly every day for at least 2 weeks. Um, some symptoms are insomnia, weight loss, depression, diminished ability to think, feeling of worthlessness, just overall just not doing very well. Typically, you're going to have some kind of a sad event that kind of tips them off. It could be something as simple and as complex as the death of a loved one, divorce, a job loss, something major. One of the things this time of year, especially to look at, as we get into more of the holiday season, that the holidays aren't always the best in the world for people. This is typically when, on the hospital side of things, that you'll start to see the psychiatric units really do indeed fill up. And the holidays are a major contributor to it. And typically it's because it reminds them of something like a death of a loved one, or some kind of episode that slips them into that major depressive disorder. Bipolar mood disorder, we also call it manic depressive illness. It's an alternating between the episodes of depression and mania. The mania is really kind of euphoric for them. They're really excited. They're overactive, kind of bouncing off the wall. I told a nursing student one time that they kind of look like a tale of Tigger and Eeyore off of Winnie the Pooh, because you have the mania that's more like Tigger and they're bouncing off the place, and then you have the depressive side that's Eeyore and they feel so sad that they really don't want to get out of bed and move and do daily activities. Um, there are two classifications of bipolar. Bipolar 1, they've had one full manic episode, and bipolar 2, they've had a hypomanic episode. Um, you should start to see a little bit of a theme when we start talking um, psychiatric illness, and that's that when we do have a flare up of our of mental disorders, it interferes with our daily life, and um, that's really kind of the tipping point of what makes it a problem, and we carry a diagnosis with that. Next one is anxiety. It's to be truly have a diagnosis of anxiety. You have to have an extreme feeling of nervousness, worry, and unease. Um, it also affects their ability to perform activities, kind of a daily function. Many different reasons that they can have an anxiety disorder. Um, they can be something as simple as just it's kind of a passing when you talk about something with heights or meeting new people or public speaking, these kind of things like that. They can be some things that people are scared of, like spiders, clowns, taxes, finances. Those things typically kind of pass. Where you have when you get to a diagnosable disorder is when that episode doesn't pass, and they stay in that state. And then you get a general anxiety disorder, panic disorders, and then just generalized phobias. Physical symptoms of anxiety. I will tell you that even though I fly on a helicopter, that I'm not a big fan of heights. So this picture up here gives me just a little short-term anxiety looking at it, and you getting on that edge like that. Physical symptoms: you can get some shortness of breath, some dizziness, some sweating, rapid heartbeat, and tremors. They can be frequent. They can be at inappropriate times, and they interfere with some activities in normal daily living, uh, and can cause problems. One of the things that you see a lot of in EMS and the ER specifically is you will have people having anxiety attacks. One of the things that you'll see is them complaining of chest pain, um, as they start breathing very rapidly and their heart starts racing and things of that nature. PTSD. It's definitely something not to take lightly, especially as I talk to y'all as a first responder type community. Um, but but this is a good definition of it. Post traumatic stress disorder involves intense, unpleasant, and dysfunctional reactions beginning after an overwhelming traumatic event. They can be things like we would typically think of war, terrorism, if you've been sexually assaulted, physical assault, if you've been in some kind of accident. But then we get to things that affect us in the first responder community, like witnessing death or a grave injury, natural disasters, just seeing things that we see that normal people can't that normal people can't deal with, and really we're not meant to see on a frequent basis like we do. A lot of PTSD symptoms um, revolve around the anxiety continuum. It is actually an anxiety part of the anxiety disorders. It incorporates reliving the event and that causes the anxiety. Symptoms uh, are simply could be just an avoidance of any kind of reminder of that event, a place, a color, situation, a smell, something like that. They can be negative thoughts that they're going to have, and it affects their affect. Um, you can have things that where they're going to have flashbacks that can cause triggers. Some people will know their triggers, some people won't. A lot of people that do know their triggers tend to stay away from those. If anybody does have PTSD, I would tell you to do get some help, and because that is something that is plaguing our industry. Overall, they're going to have changes in alertness, and the reactions are going to kind of be what you wouldn't see from a normal individual, um, given that situation. As far as treating people that have PTSD, you want to create a rapport with them. Um, you want to tell them everything that's going to happen. They're going to be kind of anxious and paranoid, most likely. Ask them to work with you. Above all else, be honest, and be honest with all of your psychiatric patients, so you can create that good rapport. You might actually need to use some kind of restraint on them. Um, Physically, you might have to physically restrain them if they're in an episode. Um, if you could very well need to use some kind of chemical restraint to kind of get them through the worst part of it, and those could be benzos and possibly paralytics. Sometimes when you have those people, sometimes the best way to take care of them to keep them safe is to take away their ability to move, and so you might have to do something like Scott talked about, and intubate them and let them work through that. Um, Sometimes um, with any kind of psychiatric illness, you can see some self harm. Sometimes it's in the form of actual things you can physically see very easily and common that we think of, which would be kind of self injury and self inflicted acts of really kind of violence against yourself. Um, Typically, self harm isn't intended to be a cause of death. One of the best explanations of this I've seen recently is with the Colorado Children's Hospital. They have a free CEs that you can get on every month, and they talked about specifically pediatric self harm and pediatric suicide. And a simple Google search will get you to their website and look for their EMS education or their continuing education, and it's a play on demand. But they talked about specifically the state of Colorado, how they're seeing a lot of self harm, and they define the difference between self harm and really suicidal behavior. Self harm can also look different in the fact that um, it may be something just as simple as them not taking care of themselves willfully, and just neglecting themselves. So um, always have that on your radar as well. Um, Self harm is very common with other psychiatric disorders. Typically, you're going to see them going hand in hand. The long term risk is them contemplating and completing suicide. It starts in adolescence and usually resolves with age, hopefully. But if it doesn't, those people are very much at risk to complete suicide. Injuries are typically kind of hidden and hard to see because they're going to be cutting, stabbing, burns, and things of that nature, and typically don't do it where you can see it. Um, and it could be something like I said, something like neglect, where it's progressive over time. We talk about suicidal behavior. Suicide is death caused by an intentional act of self harm that is designed to be lethal. It's definitely not something to take lightly. Suicide behavior includes complete suicide, attempted suicide, and suicidal ideation. Definitely something to pay attention to, and get those people that you take care of the help that they do need. Statistically, suicide affects a lot of people. About 1.2 million Americans attempted suicide in a year. Uh, it's the 10th leading cause of death overall, which is pretty staggering when you consider what other kind of illnesses and injuries could be out there. It's the second leading cause of death for ages 10 to 34. That particular statistic bothers me, because that encompasses a lot of people kind of getting started early on in their lifetime, and encompasses later childhood to adolescence, to early adulthood, and kind of that middle age. Um, it's a pretty big group of people. Um, Over 55% of males involve a firearm. 31% of females involve some kind of poisoning. There is a psychological component with that. Law enforcement folks are trained to look for that, and to deduce from that. 29% of males and female in suicides involve suffocation, which I think is another interesting statistic as well. Um, So suicidal behavior includes the completed suicide or attempted, and just the thoughts of actually doing that type of behavior. Depression is the strongest risk factor. Uh, they typically will use multiple different kinds of methods. There's going to be the typical violent methods that we think of, like the stabbing, shootings, hangings, things like that, and then they can use nonviolent methods, which would be like ingestion overdoses, um, alcoholism, things of that nature. Any kind of ideation or expressions, treat them serious every single time, because it's better to err on that side as opposed to dismissing them. When you look at an assessment, you need to ask a couple different questions. You need to ask, are you going to kill yourself? And how are you going to kill yourself, or do you have a plan? The third question that I add in from the hospital is do you have access to this? Um, and that the reason I ask that question is the problem where in the first responder and the emergency medicine community where we get jaded is there's a lot of people that use suicidal ideation as a cry for help, and they just don't know any other way, but they're really not serious about suicide. Um, and it makes us jaded. But the flip side of that is that we do have to treat every single person like they are serious, because it is a very, very serious um, problem. Switch a little gears here, and we're going to talk about excited delirium. It's a it's a very popular term that we've used over the last few years. It's been around for a long time. Some of the first times that we reference it were in the 1850s, and we first referenced it as Bell's mania. This is a true emergency, and we need to identify it quickly, and we need to treat it quickly because it can really save a life. A good definition is up on the screen now. It's delirium with agitation that includes fear, panic, shouting, violence, and hyperactivity, and that would follow by a sudden cessation of struggle, respiratory arrest, and death. In the majority of cases, unexpected strength and signs of hyperthermia are described as well. These people are just really, 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 really worked up, to the point where their body is in complete overload. And if we don't treat them and recognize it quickly, things can turn south really, really fast on these folks. Signs and symptoms, we can see or bizarre aggressive behavior, shouting, paranoia, panic, violence, unexplained physical strength, and hyperthermia. The striking statistic is 2/3 of people actually truly in excited delirium will die. I mean, that's over 70%. That's a huge number. Um, a lot of times it's because we don't recognize it. The other thing is a lot of times that they're getting not they don't the portrayal of the patient isn't the best it could be, and typically they're causing some problems at home, which gets a law enforcement um, response first, which is good to help get them under control. But at the same time, if we spend too much time not getting a medical care, then those patients can die as well. When we look at the pathophysiology with it, and they start looking at these folks, they're going to have um, things like cerebral edema, pulmonary edema. Rhabdomyolysis is very, very common in those patients. Renal failure. They're going to have hypertrophy of the myocardium, and fatal arrhythmias. Any one of those up there can cause big problems, but you're typically going to have a combination of a lot of those. Like I said, when those people are just, their bodies are in just complete overload, um, you're going to see the rhabdo pretty predominantly, which is going to contribute to the renal failure. And then from there, everything just cascades. Like I said, recognizing these people and really getting them under control, for a lack of a better term, is extremely paramount. When we look at contributing factors, a lot of it's drug use. You're going to have cocaine, methamphetamine, designer drug kind of use and abuse, and alcohol. When we look at our area specifically, we see a lot of methamphetamine use and we see a lot of alcohol use. It's just the simple facts of the area that we're in. Um, and then you have a pretty good population of unmedicated psychiatric patients. As psychiatric patients as a whole, one of the frustrating parts is that they get put in the hospital and then they don't do their follow-up care. So they get off their medicine. They try to self-medicate with one of the above substances, and it just puts them in a spiraling situation. When we start looking at treatment for these people, a lot of times physical restraints are going to be ineffective and dangerous. They're just so worked up that they're going to end up hurting themselves or hurting someone else when you put them in restraints. I mean, I've seen excited delirium patients with superhuman strength where they'll break, you know, leather restraints. Typically, you're going to have to use some kind of chemical restraint on them, some ketamine, etomidate, and probably most likely intubate them until we can get them through um, the crisis phase. A lot of times you're going to have law enforcement, especially on scene, to ultimately make sure the scene is safe and for your safety. Unfortunately, with these people, they get aggressive pretty quickly, and so sometimes extreme forces have to be used to keep everybody safe, and that's just the sad reality of it. But you do ultimately need to keep yourself safe as well. When we start looking um, at the behavioral patient and we start examining, and so we can identify some of these disorders. This quote is pretty good. In many cases, you can reassure the patient by speaking with them empathetically and professionally. After the crisis passes, the patient can be more cooperative and coherent, which makes things much easier for you to manage. I know from working on the hospital side of things, you see this a lot. You'll have law enforcement or EMS bring in someone who is having really a psychotic episode and they're worked up. But once they have time, with most people, when they sit down and you get them either some medication to help them kind of calm down, or then you can have a conversation with them, and things tend to go well, and they have some self reflection. They typically can talk their way through it, and really there's some good outcomes from it. Just asking questions gets you a lot of basis. So the first and probably the most is, do you want to hurt yourself or someone else? That's keeping them safe and keeping everybody else safe. Um, like I talked about with hallucinations, you need to ask them if they're seeing things or hearing things that nobody else is. One of the things that I've talked with patients before is someone talking to you, and I should be listening as well. And if that's not happening, then that's a good thing, because sometimes they, like I said, they don't realize they're actually having a hallucination, because in their world, in their mind, everything is very, very real. If you have a known mental illness, have they been taking their medications, or has there been a change? Unfortunately, with psychiatric medicines, there is a time period that we need to make sure that we get a good blood level on them. So it takes some time for the medicines to really be effective. So if we're playing the game of changing their medicines or adjusting dosing, that's a good thing to know. We need to ask if we've taken any substances that aren't prescribed to us. Like I said, a lot of these patients, if they haven't been taking their medicine, they're going to be supplementing with something, and then ultimately their family or their caregivers or their friends or somebody that normally comes in with them is going to be a good resource for you, because they'll let you know if what you're seeing is really typical of them and how long it's been going on. Because a lot of times the patient, when they're having a mental illness break, they don't have a good grasp on reality or time, especially time. Days run together, and they're not going to know how long they've been really having that break. So when we look at some common medicines, we won't go over all these. I would tell you to be familiar with them, just so you know what they look like, and know what they're used for. by no means does probably anybody on this call know what all these medicines carry with their own unique side effects, but knowing what the typical ones are that we see prescribed a lot. Most all of these names that you see up here are brand names. They're not really so much generic names, but I would tell you to snap a good picture of it and then start looking up the generic names, because if you go to a house somewhere and they bring you their pill bottle, a lot of times they're going to have a big generic name on there and not the easier or sometimes more easier to read brand names. Talked about safety a little bit before, but in all seriousness, that safety is very paramount, and it's your number one goal. Specifically, your safety. You've got to make sure that you're safe. What I tell new people getting into the pre-hospital world is the biggest shift I saw coming from the hospital, the pre-hospital world, was that there's a big emphasis on the provider safety in the hospital world. Not that there isn't in the hospital world, but the pre-hospital world has a bigger emphasis on that. And it's simply because if we get hurt, then there's really sometimes no backup, and if we get hurt, we're useless to anybody else. So you have to protect yourselves, and ultimately with these patients, you're going to have to protect them from themselves. Make sure you have enough resources, enough personnel. Make sure you have the right equipment or medications available to take care of them. If you get in a situation where you're with them face to face or in the back of the ambulance, make sure you have a way out of the scene, out of the room, so that you're not getting yourself hurt as well. This is an actual real life scenario that happened in Arizona a few years ago. It's really talks about being vigilant of your surroundings, but it was a fire engine that was dispatched to an apartment complex for a nosebleed. When they got there, they found a shirtless man waving a gun, which is never a good thing, I don't think. And he had blood on his chest. I mean, you could surmise really fastly that that's from his nosebleed. I can't really explain the gun, but these guys did the appropriate thing. They immediately vacated the area and they called local police. Um, it's a good thing they did. You never know what someone's going to do with a weapon that they're also bleeding as well. In the end, it was determined this patient was really just trying to complete suicide by cop. And then the rest of the story is that the local law enforcement there was able to get this guy under control, and getting the help that he needed. And he didn't become a statistic and didn't make the nightly news for that. So kudos to all those out in Arizona that did this one. When we look at another one, this is from Minnesota in 2014. It's a 68-year-old man that attacked 4 nurses with a metal pole there in the hospital. 2 of the nurses were injured. One suffered a pneumo, and the other a broken wrist. So he kind of took him and beat him pretty good. What I think is interesting is he got out of the hospital, and then it took police that chased him for almost 3 blocks, being 68 years old, before they apprehended him. Kind of tells you that age really isn't a good predictor of whether or not someone's going to hurt you or not. And if they're mobile and they can, you have to assume that they carry the ability to really do some self-harm to you. But moving on, significant violence. Those that are likely to commit significant violence, typically they're going to have something aboard, alcohol or illicit drug use. They're going to have some kind of delusion or hallucination that's going on. And the ones that carry a diagnosis of a mental illness that are non-compliant with their medicines, they're going to give you the possible biggest problem. The other thing to remember is that 24% of patients with a mental illness do not seek treatment or do not seek their follow-up treatment. And they're people that should be on some medicine that aren't. So it's something to be very diligent in. If someone tells you that they have some kind of psychiatric illness, even if you're on a medical call, and they haven't been taking their medicine, that they can turn violent on you very quickly. Um, some verbal de-escalation techniques. Respect personal space. Don't get up in their grill right away. Obviously, if they're hurting themselves, you have to make sure that they're not doing that. Don't be provocative. Don't provoke them. What I will add is if there's somebody on scene that is provoking them, or even if you're the person, just by you being there is provoking them, if there's somebody else that can take over for you, don't have the hero complex, but get someone in there that can really de-escalate that situation. You want to make sure you have verbal contact with them. You want to be very concise, be very specific with them. Um, Reiterating what they're telling you to make sure that everybody's on the same page is a big thing. Identifying wants and feelings is another thing that's huge. Um, just have some good listening skills and listen closely. Don't get it in your head that this is what they're actually here for, even if it's somebody you've dealt with, 200 times before. Really listen closely to what they're saying. Um, agree to disagree with them. That's fine, but make sure you're setting good limits on them, and really clear limits as well, and establishing that you are the authority in the situation. Offer some choices. That gives you some control, and really be optimistic with them when it's warranted. Encourage them to make good choices, which is really helpful. Um, if you have to restrain them, if you have to lay hands on them to get them under control, make sure you talk to them about that afterwards. If there's staff involved with it, make sure you debrief the staff as well. Don't be afraid to ask what could we do better. Ask what we did well, and really what we could do better. It really promotes and really does well for everyone involved. If you should have to move, um, to actual physical restraints, remember that we need to use those limitedly, um, and they're there to limit the patient movement as a whole, movement of the limbs. The biggest thing with physical restraints is they require continuous monitoring. Someone needs to be sitting with them and laying eyes on them the entire time, because they can really cause some problems. Someone needs to be sitting with them to identify if maybe they're having a if they're really not conducive, and we need to get a chemical restraint on board as well. The biggest problem with using physical restraints that you see is that they can cause a lack of perfusion to the distal portion of that extremity. So you need to have someone checking and making sure they still have blood flow to their fingertips and their toes and things of that nature. A lot of times physical restraints won't work, so we need to use some good chemical restraints. A lot of people in the area, I don't know that everybody is, but a lot of people are carrying ketamine. It's really one of my favorite drugs to give to people if I need to kind of get them under control. Use a lot with excited delirium. Um, it's a very good drug. Um, it really carries very minimal side effects with it that I've seen, and you get some good dosing parameters. Versed, the benzo, which is good as well. Um, we give Ativan is another benzo that we give. Haldol is something that's more likely used in the hospital. We do use that as well. Above else, I know we've got some dosing parameters on this slide. Make sure you're following your local protocol or any kind of physician orders that you get. If for some reason that one of these doesn't work very well and you've got somebody just in a full-on psychotic break, there is a time to protect everybody where you're going to have to completely sedate them and paralyze them and perform an ISI and intubate them. With any drugs that we give, we want to make sure we have the right patient, the right drug, the right time, the right dose, and the right route. One of the things we use on the aircraft is we use what's called a MAC check, which really kind of goes over these 5 rights of medication administration. but it's bouncing your what you're given at 2 o'clock in the morning off of your partner and making sure that you haven't done math wrong, and then you make sure that you haven't moved a decimal place where you're not supposed to put a decimal place. But remembering these 5 rights is a big deal. I'm going to shift gears just a little bit. I want to talk about, because I think we'd be remiss, especially in this lecture, not talking about some of the bad things that we do see, and really in the first responder community, making sure that we know that it's okay to not be okay. It's a difficult thing to talk about. I've been privileged enough to be practicing in the Joplin area for a while, and unfortunately, we're not immune to this. The biggest thing on this slide that is a big takeaway for me is that just our profession makes us 1.3 times more likely to die by suicide than any other person. I can't stress enough that if you've got feelings of hopelessness or anxiety or depression and PTSD and symptoms of those things and you're not seeking help, please do. I can tell you that I know most or have a relationship with almost all the leadership, and whether it be in an ER or fire department or an EMS service in this area, and I can't tell you one person that would not be that's in leadership that would not want to know if you're having one of these and to get you the help that need. There's the Code Green campaign and the National Suicide Hotline on this place. I will tell you, there's a lot of other places. Just off the top of my head, the Echo Foundation is one of them. But get you some help. Sometimes it's just as simple as talking to your coworkers. I mean, you've got people in this profession that have been around for a while, and everybody has their own coping techniques. But it's definitely something that we do need to talk about, and that we do need to really address. As some of us seasoned or even some new folks that come in, if you see someone starting to exhibit some signs, be the bigger person and go to them and say, hey man, hey young lady, are you all right? Is there something that we do need to talk about? I've worked with a lot of people in this area, and I don't want anybody to become a statistic. So in summary, mental health is definitely a big deal. It's an emergency. Mental health disorders and medical disorders a lot of times will go hand in hand. You're going to see those. The providers are there to protect and the patient from harming themselves and others. When we treat folks, we've got to sometimes use some physical restraints, and we got to sometimes have to use some chemical restraints. Above all else, we need to make sure that we're there to listen and talk and be on our best game when we're taking care of folks. Ultimately, as a provider, it's okay to not be okay. It's definitely something that we need to talk about, and we need to debrief, and we need to make sure that we get the help that we need as providers. With that, I will tell you that there's a QR code there for some CEs. I know that Kyle and Jeff are taking care of CEs as well. And it looks like I got done with about 15-ish minutes to spare. And so we'll put this up here for a little bit, and then we'll switch over to the next one, and we'll be back with you shortly.